Ladies and gentlemen, sorry, I was facing some technical challenges. I've been trying to fix it up. Um, it's like whenever I started live chat, I noticed every 2 minutes it tells me that there is a problem. I don't know whether it's in the internet or. So, hello, ladies and gentlemen. Today's discussion is going to be about hemorrhoids and its management. When we talk about hemorrhoids, we are talking about loosed or enlarged anal vein. Okay, the vein in the anal region, the anal canal, the vein has become loosed or has become enlarged. Okay, and that same knowledge is being applied with varicocele. Varicocele means loosening of the walls of the uh, of the how do you even call this? The veins that supplies the testicles. Okay, that is varicocele, loosening of the wall. Okay, uh-huh. And then the same thing applies to varicose veins, those veins that appears on people's legs. You see more like a thread-like structure, plenty veins on the legs. That one too is the same thing. It means the walls has been weak, is weakening of the walls of the vein. Okay. So usually there are drugs we can give to strengthen the walls of um, such patients, and the drug is called Phlebodia. It comes in 600 milligrams. So you can do 600 milligrams daily for 30 days. I mean, I've tried it for some patients and it has worked like magic. Okay, so we have types of hemorrhoid. We have um, stage one, or we call it first degree hemorrhoid. We have first degree hemorrhoid, second degree hemorrhoid, and third degree hemorrhoid. So if someone asks you how many types of hemorrhoids do we have, you tell them three. Per the STG, there's three. There's three. We have first degree hemorrhoid, second degree hemorrhoid, and third degree hemorrhoid. First degree hemorrhoid is within the anal cavity. Okay, second degree hemorrhoid is outside, but when you push it in, it can go. So second degree hemorrhoid is reducible. Okay, it's reducible. But excuse me, third degree hemorrhoid is prolapsed. So it's prolapsed, it's outside. When you push it in, it doesn't go, it's irreducible. So that is third degree hemorrhoid. So why should you be concerned about hemorrhoid? This is because you might be dealing with a malignant condition. Probably there might be a tumor in the rectum or tumor in the sigmoid colon. When you see the patient, when you examine and you realize that the stool is mixed up with blood, then that should tell you that it could be malignant. Okay, when the stool is mixed up with the blood, after doing the rectal examination, you realize that the stool is mixed up with blood. It doesn't matter the color of the blood. It can be frank blood or blood that looks a little dark colored. Okay, and so when that happens, you need to exclude the malignancy. Why should you also be concerned about hemorrhoid? Because it can lead to low HB, it can lead to anemia, and the anemia can go a long way to affect the kidney and cause renal failure. It can cause renal failure. It can cause acute tubular necrosis and end up causing chronic renal failure. So you can see how this simple hemorrhoid can lead to something else. And then if it's having anemia can end up leading to heart failure because the heart can end up pumping for a very long time, and uh, at the end it can lead to heart failure. Yeah. So there's a mnemonic called heart fails. H is for hypertension, E for embolism, A for anemia, R for rheumatoid arthritis, T for thyroid toxicosis, F for I don't remember the rest. But then they are there. I'll look for it and then share it with people. It's a lot. It's the mnemonic. It will take time for me to remember all. Right now, it's already late in the middle of the night, so I can't really think like broad daylight. It is difficult to think around this time, but I'm trying hard to think. Okay, so when you have a patient like this, what are some of the causes of hemorrhoid? So they can ask you. Pregnancy is one of the main things. So far, I think most pregnant women I see have hemorrhoid. Most pregnant women. So when there's a slight increase in abdominal pressure, it causes hemorrhoid. Slight increase. Baby has come, boom, hemorrhoid. So those are the main things. Most pregnant women end up having hemorrhoid, and you have to be careful when giving medication because you are dealing with the fetus and the mother. So you have to exercise extra precautionary measures when giving such medication. If possible, you can refer because Charlie, you wouldn't want to put yourself in trouble. Yeah. So increase in abdominal pressure, and then and then there's cough. When there's a chronic cough, someone is coughing for a long time, it can cause increase in abdominal pressure. Increased abdominal pressure can lead to hemorrhoid, or even it can even lead to hernia. Okay, pregnancy is also one. Intra-abdominal malignancies or tumor or pelvic tumors, they can all cause hemorrhoid. Excessive straining at stool from constipation. So when someone is straining so much because he's highly constipated, those are some of the things. And then familial predisposition. There are some family members that they only all of them have uh, some form of sorry some form of hemorrhoid. Yeah, so it can be familial. It can also be a sign of a chronic liver disease with a portal hypertension. That is also possible. Um, there can also be anorectal tumors. Okay. So what are some of the signs? They'll tell you that, oh, I'm passing a bright red colored stool. Or they can tell you that it is not mixed, the blood is not mixed with the stool, it is just red blood that is coming out. Another thing, uh, this STG has book, but in real life, if someone is bleeding too much, you can give tranexamic acid and then you do your. So right now, the person is bleeding. So the first thing, so in this case, if you don't do full blood count as part of your management, you have failed. And in real life, if you don't do full blood count in this, you have failed. Because someone is bleeding, any form of bleeding, there you need to find out if the blood, the state of um, the hemodynamic state of the patient is very important. So you don't just give IV fluid. When you do that, you are causing hemodilution. You understand? When you give IV fluid in severe anemia, you are causing hemodilution. So you don't do that. You see if there's a possibility for transfusion. Also, you see whether the patient has signs of anemia. If the patient is not showing signs of anemia, then you use your own discretion. Okay, so you transfuse when the patient is symptomatic of anemia. But that is book. But in real life, if you see and the HB is like 5 point something and below, my sister, my brother transfused. Don't go and follow book and get yourself in trouble. Okay, so first, the core mandate is to look for blood. Another core mandate is to what? Um, secure hemostasis, or you have to stop the bleeding. So you can use tranexamic acid, IV tranexamic acid, like about 1.5 gram stat or something. The oral tranexamic acid comes in 500 milligrams. So you can do 500 BD for 3 days. That is also fine. I've seen some people give tranexamic acid as high as 2 gram and then 3 grams. Yeah, some people, but me, I won't do. So what I can do is 1.5, and then you monitor, and then you work your way out. Okay. Uh-huh. So they can also come and tell you that when they went to the washroom, the stool just the blood just splashed on the seat, and then the whole place was bloody. That's another symptom they can tell you. They can also tell you they are seeing some mucoid discharge in their anal region. They can also be swelling. They will tell you that my anus is swollen. That is not rectal prolapse. So by the time I tell you that the anus is, so when you look at it, you realize that it's actually hemorrhoid. Okay. So they also come with pruritus ani. Pruritus ani means itchiness around the perianal region. So some of them you see them putting their hands there and scratching. So there's itchiness around the perianal region, and also that's a sign of loosening of the walls of the veins in the anal region. Okay, or the enlargement of the veins in the anal region. That's so pruritus, itchiness, and me is anus. Hey, why am I even planning to point my anus, please? And they can also tell you that they have discomfort after opening, like going freeing their bowels. Okay, some can also tell you that there's anal pain. So usually in the management of this condition, we have drugs we normally give. You can give your Flebodia or your Deflon. Flebodia or Deflon, you give your Anusol, and then you can give your tranexamic acid, then you give what your blood medication or whatever it is. If they are in pain, you manage the pain. Okay, okay. So since you are planning to rule out tumors, you have to do a digital rectal examination. You have to examine the anus very well. So you use this your mighty finger. Okay, you wear two gloves or three. Usually I like to wear two. And make sure you lubricate your finger, and then you stick your finger into the anus, and then you go 12 o'clock, 3 o'clock, 6 o'clock, you come down. So you are looking for any malignancies, any form of malignancy. And when you do that, you try to scoop out some of the stool, and you look at the stool, you examine it carefully, you see whether it is stained with blood or it is a normal stool. You look at it, whether it is stained with blood or it's a normal stool, and then you do your documentation. But also you have to look at the anus. You also whether there's anal fissure. Okay, you're also looking at skin tag, and you're looking at the anal tone. You're looking at the tone, the ability for the anus to grip your finger. Yeah, whether the tone is if the tone is loose, you are suspecting LGBTQ. We are suspecting homosexuality. But if the anal tone, sphincter tone is okay, then it's normal. Okay. And then also you are looking out for blood, you are looking out for you know malignancies. That's the most important thing. So such a patient, you might if you are suspecting malignancy, the best thing to do is to do what? A sigmoidoscopy or something, just to look through the colon to be sure that everything is fine. Okay. So what are some of the signs? There may be no signs on inspection. On inspection of the anus and the digital examination, you might not find anything. And then also you might find some redundant folds. You see skin tags at the anal region. And then you can also see swelling of the anal around the anal region and all. Also, you may be able to palpate a thrombosed hemorrhoid. Thrombosed hemorrhoid means you see that there's a stain of clotted uh, hemorrhoid. You see that it is a little thrombosed. If you see thrombosed, you know how it looks like. So all those things they come with the same management. Sometimes at the surgical unit, you let them sit in. They can do hot bath, sit bath, no, sit hot bath. One of those things. So you get a bathtub, a big basin, and then you put salt in it, and then sometimes you can put chlorhexidine, that's Savlon in it, and then they sit in it. Not too hot water, like a moderately sensible amount of water and temperature of water that is okay. They let them sit in it. I mean, um, it helps to reduce the size. Okay, especially for pregnant women. So if the patient is having um, profuse rectal bleeding, then it means you are looking at anemia. The anemia can lead to hemorrhagic shock. The hemorrhagic shock too can lead to a lot, renal failure and all those things. Uh-huh. We're also looking at it can also cause thrombosis and then infection or ulceration. Some of the signs you see pallor, you see conjunctiva pallor, palmar pallor. Sometimes they can ask you what are some of the signs you may see, and if you don't have anything to say, you can comment on those things. So with the with the investigations, you do your full blood count and your proctoscopy. That is the gold standard proctoscopy, and then we have the sigmoidoscopy. This one I said it the last time. It is to rule out malignancies. So with the treatment plan, we have the pharmacological treatment and the non-pharmacological treatment. So with the treatment, you correct the anemia if it is present, you relieve pain. If the person is pregnant, you stick to your paracetamol. Because when you give NSAIDs in a pregnant woman, it causes the premature closure of the ductus arteriosus. It's very important. You have to be able to. So when the person is pregnant, you don't administer NSAIDs because it can cause premature closure of the ductus arteriosus. Okay, so you stick to your paracetamol, and then you can do your sit hot bath. So with the treatment, you correct anemia, you relieve symptoms, and then you prevent complications from happening. So um you let them increase with the treatment, sometimes most of the times you let them take in more fluid, okay, and then more roughages. You let them take in more of cabbages and carrots and those things. Very important. So you can apply anesthetic cream. We have anesthetic cream that helps to relieve the pain. I think anosol is also one. Also, you can apply cold ice compressions on the prolapsed hemorrhoid. Okay, and then you can also sedate the patient if it is very painful. You can do sedation. Okay. So if for infected hemorrhoid, you do warm sitz baths 2 or 3 times a day. So when the hemorrhoid is infected, you do warm sit baths, okay, morning, afternoon, and evening. Or you can do just morning and evening. Okay. So some as part of the treatment plan, sometimes they can do rubber band ligation, and then the second for second degree hemorrhoid, that is a hemorrhoid that is able to go in and come. It's reducible hemorrhoid. You can do rubber band ligation, and then you can do hemorrhoidectomy for third degree hemorrhoid. That one they are already outside. They are irreducible. So that one you can do hemorrhoidoscopy, and you can do hemorrhoidectomy for them. So hemorrhoid developing during pregnancy should be managed consecutively, as most will resolve after delivery. So most of the times it resolves after you've given birth. The hemorrhoid goes away. So just manage the pain and all those things with paracetamol. Okay, so with the pharmacological modeling, we are looking at liquid paraffin. It's 10 to 30 mils every night. We're also looking at Cina. So most of the drugs here are some of the drugs I think we treated them in the gastroenteritis also. No, in constipation. Most of the drugs here are drugs that we treated when we're doing the constipation. So I think most of you are aware of it. So you can do I'm sure most of you know lactulose. So you can do liquid paraffin, cinnamon granules. That's one sachet with water after supper. And then you do um, when it is associated with local itchiness or discomfort, soothing agents with or without steroid may be applied, or you can insert it rectally. So you do it one suppository anosol. Okay, that is a soothing agent. Suppository anosol, maybe one twice daily for 7 or 10 days. For infected hemorrhoid, you do gentamicin, you do metronidazole, and then hey, am I getting it right? Okay, so gentamicin and metronidazole. That is evidence rating one. And then with evidence rating two, the second line treatment, you do Cipro, metronidazole, and then the third line of treatment, you do amoxicillin, metronidazole. So you can either do gentamicin and metronidazole, IV gentamicin and metronidazole, or you do ciprofloxacin and metronidazole, or you can do amoxicillin and metronidazole. When the hemorrhoid is associated with anemia, you make sure you correct it. Iron ferrous sulfate is very important. So that is the end of today's discussion. But we have criteria for referral. So you refer patients to a facility with resources for rubber band ligation. And we said that the rubber band ligation is for stage 2 hemorrhoid. Okay. So please, if you have any question, you can ask. You can also refer patients. Okay, so let's put it in an MDC way. Okay, in case it's an MDC exams, how will you manage these patients? So first, you will still go right, even though it is rectal, you still go and assess airway for patency, ensure breathing, ensure circulation. Okay, and then you can say ensure um hemodynamic state stabilization. That is just to make them know that you want to be sure that the patient is not anemic or something, and then the hemodynamic state is okay. And then you admit, you take blood sample for full blood, no, take blood sample for laboratory investigation. Okay, then you control pain using paracetamol. If the patient is pregnant, you stick to your paracetamol. Okay, so you use control pain with antipyretic. Okay, you don't say control pain with paracetamol. Say control pain with antipyretics, and then advise patient to take in adequate amount of water, and then you ensure adequate hydration. Very important. And then you take blood sample for grouping and cross matching, because these patients you may not know might be needing blood transfusion because the person is having rectal bleed. So the person might be needing rectal blood transfusion. So you do grouping and cross matching for the patient. And then what again? What again? Yes, you do. So I think that should be okay for. And then you set IV cannula, two large bulb cannula, and ensure adequate hydration. I think I've said that already. And then you refer patients. So you won't just say refer. Okay, that's a big problem. So as a clinician, you should know who you are referring to. So you write, this is a surgical case. So refer to see a surgeon for further management. So if the case they presented, maybe a 23-year-old man presented with um, bulging or something at the anal region, and on examination it was reducible. Now they're telling you it was reducible means it is stage 2. So they'll tell you, oh, it was irreducible, it was prolapsed and irreducible. That is stage 3 hemorrhoid. So as part of your management, you have to say refer to see a surgeon for further management, or refer to see a surgeon for. Normally, it's not advisable to write to go and do hemorrhoidectomy or whatever it is, don't put that there. So refer to see a surgeon for further management. I think that makes sense. Uh-huh. If you have any question, you can put it in the comment section so that I address it. I'm waiting. Hey, or everybody is asleep. If you are not asleep, say something. Me cry the way I'm feeling sleepy. Waiting. Any question? Any question? I'm waiting for questions. So please, if you have not bought the STG, make sure you buy some. Okay. I'm not selling it. I don't know, but if you go to Kolebu, you will get some. It's very important. So in this case, there's lactulose. You can use lactulose. You can do 10 mils BD. That's fine, or 15 mils BD. Or 10 mils BD is fine, so that they can have soft stool and be able to poo poo. What is the best treatment of hemorrhoid if the hemorrhoid is infected? Okay, so once the hemorrhoid is infected, we allow the patient to do warm sit baths. So you do sit baths. That's the best way for treatment. So they'll sit in the hot warm sit bath, and then the warm sit bath we use salt, and then I think chlorhexidine, that's Savlon, for it. But I'll look for the main what the surgeons use. But I know it's a salt. They add salt, and then they have something they add to it, and it helps the infected hemorrhoid. You know, but you can cover up with antibiotics, and the antibiotics they recommended was gentamicin and metronidazole, or ciprofloxacin and metronidazole, or amoxicillin and metronidazole. Yeah, yeah. But basically, for infected hemorrhoid, it's water, warm sit baths. Yeah. I'm waiting for more questions. Waiting. Okay. So in the absence of, we've been able to finish this early today. So in the absence of any other further question, we would like to bring today's discussion to an end. The next discussion is going to be amoebic liver abscess. Amoebic liver abscess. And then the next discussion too is going to be about jaundice. So with the jaundice, I'll try and touch on neonatal jaundice in addition to all those, in addition to all the jaundice at once. So you better go and learn about Crigler-Najjar 1 and 2 and biliary atresia and all those things. We'll do that. They said, what of if infected and also associated with anemia? Okay, so if the thrombosed, if the hemorrhoid is infected and is associated with anemia, like I said, with STG, the STG didn't say do blood grouping and cross matching, but every clinician, if you do your full blood count and you think the anemia is very profound, the next thing is arrange for blood. So you do um, grouping and cross matching and start searching for blood, and then for possible blood transfusion. So if it is infected, you do your warm sit bath, you add your um how do you call it, your warm sit bath, you do antibiotics cover, that's gentamicin or metronidazole, or ciprofloxacin and metronidazole, or amoxicillin and metronidazole, and then you do um you arrange for blood. If there's no blood, you can do we have an injection we give actually. Um it's erythropoietin, erythropoietin injection. It also helps blood to come very fast. Okay, because the kidney does all those things. So it's a bypass. Instead of taking blood for the blood to come and produce no, 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 no. You can just give injection erythropoietin and you can increase the HB very fast. Also, I would one day share something with you. It's a research they have done. It's on uh, a certain condition. I'm trying to remember. Uh, it's a way of conserving blood during surgeries. Allogenic transfusion. Allogenic blood transfusion and all. Yeah, one day I'll share those information with you guys. And so you can just do Totema in real life. You can do Totema and then advise them to get all those their bedroom and all those things whilst you are looking for blood. And then you have to be cautious when you are giving IV fluid because it can cause hemodilution. When you are managing severe anemia, don't be quick to give IV fluid. It will cause hemodilution. So that is why if you check the blood, okay, the HB, the hematocrit, okay, the HB is usually times uh, if you multiply the HB times 3, you are supposed to get the hematocrit. Okay. However, hematocrit divided by 3, you are supposed to get the HB. The range it should be plus 2 or plus 3 deviation differences. You understand? Uh-huh. So you don't cause hemodilution. You can't let the HB be 6 and then the hematocrit is now 50. No, it can't happen. So when that happens, it puts pressure on the heart because already when there's anemia, the heart now starts pumping so much to push blood, especially the left ventricle. And there's also demand from the pulmonary. Um, okay, this is coming from here. A pulmonary artery. Yeah. So there's so much pressure on demand and supply. You understand? And sometimes it can end up causing aneurysm because the heart is pumping under high pressure. So there can be weakening of the vessel, and that is aneurysm. At a point, you may have to do an anastomosis, okay, to strengthen the walls of um, the vessel. Yeah. So if you have an anemia case like that, you can do your thought hammer whilst you are looking or waiting for the blood. But don't give you can do IV fluid, but you can let it flow very slowly. You can do like 1 liter or 500. Okay. But don't load the patient on the normal usual maintenance fluid. No, 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 no. If you load them so much, it can cause hemodilution, and that can also lead to their untimely death because it will also put pressure on the kidney, which also operates with blood. But this time around, you are giving it excess water for it to do ultrafiltration and selective reabsorption. Charlie, your head is hard. Okay, so normally when there's severe anemia, you don't go and look for plenty IV fluid, thinking that if you pour more IV fluid, it will cause no, 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 no. You can do gentle rehydration with IV fluid, small, small, maybe 1 liter per day or something. You understand? Whilst you are waiting for the blood, you can be doing that. Okay, so I'm waiting for another question. I'm waiting for another question. I'm waiting. I'm waiting. Waiting for more questions. Okay, so in the absence of any question, any more question, because there's no other question coming, I would like to end today's discussion. I'm so happy to have you people here, and I'm so happy about your contributions today. I hope I hope to see you next time. So next time we'll be discussing amoebic liver disease. Hey, I think it's amoebic abscess, amoebic liver abscess, and then we'll be doing jaundice as well. So try and read around so that you can easily understand everything. Thank you so much for being with me. Bye.